Senator Carroll, Senator Douglas,
Present.
Senator Elkins, Senator Funky Fromeyer, Senator Nemus,
Present.
Senator Tishner, Senator Wise,
Aye.
Chairman Meredith.
I'm confused.
Still need my coffee.
Here, yeah.
One said aye.
Oh, okay.
Thank you, Senator Wise, for that.
Tell I'm supportive of this.
And anyone else need coffee this morning before we get started? Appreciate everybody attending this morning, this special meeting. We've got a very unique situation. I'm reminded my first week here in 2017, my good friend Senator Steve West told me, he said, every bill that's passed has unintended consequences. And certainly then from Senate Bill 280 and 281 we saw earlier in the session, we want to make sure there are no unintended consequences. Now we'll be able to address them all, but you see we have Pikeville here at the table with Senator Wheeler, as well as Mark Birdwhistle, who we all know from UK. I tell you, there has been numerous conversations since we originally heard this bill amongst this group, and I want to commend them for that, as well as Kentucky Hospital Association for their involvement. There are more moving parts of this than you'll see at a Taylor Swift concert. Not that I've ever been to one, but just a lot of parts to it. And it is a very complicated situation. And I think what we're asking you folks to do this morning is take a leap of faith that we want to try to address this situation. But what you're going to see in this bill today will not be the final version. It's just a vehicle to allow us to continue to move forward. As soon as we adjourn this meeting, if this bill is passed, these folks will be meeting to have further discussion, and we'll hear a lot more about this later on. But that's kind of the intro. With that, Senator Wheeler, the floor is yours.
Thank you, Mr. Chairman, and I'd like to commend these two gentlemen sitting beside of me, as well as yourself, and especially Chris Joffrian, who's really done a remarkable job in yeoman's work and trying to effectuate this compromise, and will likely yet have more work to do, but I know he's up to the task. As you say, modern healthcare is a very complicated thing, and I've even, sometimes I get down into these rabbit holes that I think this Senator Adams said, why are we always dealing with Phil Wheeler bills at the end of the session? But, I guess might be because I'm not afraid to take on the tough issues. And this is a tough issue, especially rural health care. And I'm glad that within the last couple of weeks, I think we have truly moved towards a partnership between our educational healthcare institutions and rural healthcare. As we said, the original, I think we're going to move Senate Bill 280. Is that correct, Mr. Chairman? All right, Senate Bill 280, as it's originally written, was to give...
Excuse me, you have a sub on that bill, too. You want to talk to the sub?
Yes, I'll talk to the sub.
Motion, second on sub. All in favor say aye.
Aye.
All right, thank you.
Okay, the sub is not the final product. I think Mr. Birdwhistle and my friend Donovan Blackburn are continuing to work on tweaking that language. Another issue that will be resolved in the final version is under Section 5, facilities will be redefined as hospitals, so that will be one of the main thing as far as the freeze. I think Senator Adams and is a vocal proponent of the good doctors and healthcare systems at UK or U of L, and we work together on that. I think that the final product that you will see that likely comes in a form of a floor amendment this afternoon will be a compromise version that not only creates, I guess, to quote Mr. Birdwhistle, a third way to try to assist rural health care that is currently struggling in this environment. Clearly, in eastern Kentucky, we have a rather high Medicaid and Medicare payor mix, and that creates challenges. I mean, those reimbursement rates are tough on rural hospitals, as our chairman well knows. And these same things apply to Western Kentucky as well. And I do want to commend Mr. Birdwhistle for having the idea to come up with this third way, because not only will it help institutions like Pikeville Medical Center in the East, it has the possibility of helping rural health care on a statewide basis. So What we're doing today is passing the vehicle out of committee that hopefully will pick up the passenger to deliver everybody to a good destination over in the House. And so I am asking you to take a leap of faith to move the process along, but I have every confidence that we will be able to do so.
Just a note before we take question, one of the handouts that you have is a list of Medicaid eligibles by county. I think you'll find this very interesting, and to me it's a little bit alarming as well, because we have talked on numerous occasions about the inequities of the system, particularly for rural Kentucky, and this is one of the biggest challenges that we face, all of us, and it goes back to those unintended consequences. Part of our concern is how this could potentially impact the HRIP program, which we passed last session, which truly is a lifeline for rural hospitals. So that's why we're trying to go very judiciously with this and make sure we do the right things. So again, gentlemen, appreciate your hard work on this, and I know there's still work to do. But with that, Senator Frankie Fromeyer, you have a question, comment?
Yes, please. So appreciate that we've got 3 experts right here at the table. I'm a little unclear on the difference of HRIP in some of the pricing models that we're talking about, and what dilemma that we're experiencing here. I recognize that there's significant percentages of Medicaid eligible, but can you be a little bit clearer? I'm a certified financial planner, so I love the financials, I love the numbers, but I'm not fully understanding what conflict we're resolving here, and I do believe it's relative to HRIP.
Mark, before you proceed, if you would, please identify yourself for the record, and Donovan as well, just so we'll be prepared to answer questions. So,
okay, thank you, sir. Yes, my name is Mark Birdwhistle. I'm Chief Administrative Officer of UK Healthcare. If you recall, when I appeared before the committee last week, I talked about the concerns of unintended consequences. The university has their directed payment plan, and the other hospitals have their version. And I don't think anybody wanted to touch those 2 plans.
And let me ask you to pause.
That one's called HRIP.
When you describe it that way, I'm trying to put myself into the ordinary person's seat and acknowledge that part of our desire is a healthier Kentucky, but also that people really know what their cost of care is. So when you're describing this already, you're talking about 2 different cost structures, and that's super alarming to me. I'll be candid, but go ahead.
and just clarification, Senator, we're not talking about cost structures. We're talking about reimbursement. It's entirely 2 different subjects altogether.
And
Well,
they're related. They're related.
Yeah, I mean, if you didn't have a cost that was $1,000, you wouldn't need a reimbursement that's $1,000. So how could costs be so much more and reimbursements be so much less or more? That's my trouble here.
So let me give you some context. So University of Kentucky, University of Louisville, we take care of the sickest of the sick. The case mix index for our patient population, which is a measure of how their care needs are 2 times that of community-based hospitals. So our cost structure, by that factor, we do transplants, we do high-end cancer care. Our costs are just different because that's who we are. So it's appropriate that the universities have their own pool and they have their own model so that they get paid differently. The private hospitals, the community hospitals, the care needs of those patients, they're not tertiary patients. These are more routine care, and so their case mix, their cost structure is very similar. So we have 2, in Kentucky, we are fortunate to have 2 different payment models that support our ability to care for the Medicaid population. So we have federal approval of both of these plans and for different time periods. But they all are effective on January 1. They run on a calendar year basis. My concern last week with 280 and 281 is those original bills could have triggered a amendment to those plans. I was fearful that we would have to go back to the federal government and renegotiate those. So what's in the committee sub keeps both of those plans intact. But there would be a third option that would live on top of ATRIP that would, for certain hospitals that have the community funding source and they serve a higher percentage of Medicaid patients, they could tap into an add-on funding to help them to care for the Medicaid patients. So Donovan, you want to pick up the add-on piece because that's your word.
Donovan Blackburn. I'm the president and CEO for Pikeville Medical Center. And before that I answer or go deeper into that, let me kind of piggyback off of what Mark said, is when you look at Pikeville Medical Center and where we're located, we're far eastern Kentucky. To coin the same phrase, we truly do take care of the sickest of the sick and the most financially challenged in the state. When you look at the statistics across the nation, we lead the area that I specifically serve, and we are not a hospital. Just like UK, we are a regional transfer referral center. So we accept patients this past year from 48 different hospitals in eastern Kentucky for a higher level of care. That comes with a great cost associated with it, on top of being in rural Kentucky, to where it's very difficult to recruit in these specialty services that you need to be able to treat the sickest of the sick. So when you look at pulmonary, heart disease, cancer rates, et cetera, we truly are taking care of those patients. When there is a level of care because of the cost that we can't endure just because we can't operate it at a negative, then we have partners like the university that we then refer as a second tier those patients to for that advanced care. When you look at our payer mix, to his point, 77% of our payer mix currently is Medicaid, Medicare. So it's not that we can charge, in essence, what we want to charge. We charge, in essence, what's dictated by the state and the federal government. On top of it, we have a very sizable charitable component to that also. And as a Christian organization and as a hospital, we're kind of mandated to do that. But realize, too, that through our fixed costs, it takes about $1.7 million a day for our regional center to operate. We had last year 501,000 encounters in a population base that we serve about 450,000 people. So looking at the volumes that we still do, the cost of that isn't dictated in essence by us or what we charge. It's dictated by what each service line we're able to get through state Medicaid, Medicare. And where we're struggling is that under the recent conditions of what we've lived through this recent pandemic, we've seen, as everybody's aware, inflation has hit us in different ways, which has really driven up that cost. And when you're living on 1% and 2% margins to begin with, ATRIP truly was a lifeline. It was a difference in us cutting services to the people that needed it the most. This advanced payment, or the third tier, what it will do is, because of the type of hospital that we are, and that was our argument, is that there's three medical centers in the state of Kentucky, or schools. That's at U of L, UK, and University of Pikeville. The difference in the university rate is it's an advanced payment that allows them the additional funding to be able to create residency programs and doctors, to be able to fund and fuel the growth for our state that is needed. We don't have that same ability at Pikeville because we're not a state institution. So when you compete against the market, you compete against the increased cost. We see more patients coming back that delayed care. We have a higher level of acuity now than we've ever seen. We got a higher length of stay, and all that comes with a cost associated with it. So our concern in what we're providing is, I've used the example multiple times, is 15 years ago, before that Pikeville Medical Center had the Heart Institute, of the program we had, my father-in-law literally almost died and was transferred finally to UK. The fall came in, he couldn't be helicoptered out, so there was no transportation. It was a 3-hour trip to UK. So we have people that have heart disease with multiple other comorbidities that lay on a table every day that we weren't able to take care of. We're now able to do that with the services that we currently have and the investments that's been made over the last 15, 20 years in Eastern Kentucky. To go backwards to that, it interferes so many different ways. It impacts our economy. It impacts our businesses that are looking at locating in Eastern Kentucky and hopefully diversifying the economy in a way so we get and we actually generate more commercial rate. But the necessity to have additional means through this, and I give full compliment to my counterpart over here, Mark, that coming up with this third tier that will allow us to look at those Medicaid rates that Senator Meredith spoke of, and realizing that we are, again, 77% with all this contribution that we're giving back to the community for those who can't afford to pay. So this is significant in who we are compared to what a normal hospital is. So I wanted to kind of explain that we're not just a hospital, like acute care hospital. We are a regional medical center that offers a lot of the same services that a UK has. And then you have to have a higher level of tier, which is why the funding for the university rate was established and what we fully support. But the difference is that as market margins decline, then the services that we offer are at risk. And the only way to compensate is to cut out services that are needed. And the repercussions of that is that you delay care, and therefore you have sicker patients that are in the program even longer. So it may not cost you in Pikeville, but it's going to cost you at UK at a higher rate if you don't take care of it through the process that we've now and the services that we now have in place. Thank you.
Thank you.
So the attempt is to try to resolve this payment disparity and inadequacy. And as maybe you know, Mr. Birdwhistle is an expert on Medicaid. We're glad to have his expertise in this. But one of the things I'd ask you, because again, we're looking at some type of add-on for hospitals, is do hospitals have to have an average commercial payment rate above the state average in order to get the add-on?
I think that's the way we envision it, because we wanted to make sure if they're currently being paid at least the average commercial rate. We don't see that needs to be recognized, and I think there are federal limitations that would restrict us paying more than that.
Do we know how many hospitals may be impacted that by not having that higher commercial rate?
So I'll answer and then I'll defer to you. Part of
Well,
the
let me-
problem
let-
with this
Let,
is
let me say, I don't want to go in the weeds that deep. This is
Okay.
something I think you folks have to talk about
right.
if we pass this, but that's a point of consideration I want to make sure we don't ignore.
I think the overall goal, of course, of the bill is to level the playing field.
Exactly.
And so, and I hope, Mr. Chairman, you can continue to participate in these final changes because you're much more familiar with this than I.
Senator Douglas, you have a comment, question?
One of the other concerns that has been expressed to me by those who I've had conversation with is that with the acquisition of satellite hospitals, the advanced payment rate has also been something that has been used by those hospitals that have been acquired. We can use the argument that we are taking that the University of Kentucky is taking care of the sickest, but those hospitals there are not. How do you plan to address some of those questions that my constituents are asking in that particular space, because they have hospitals that will not be receiving that advanced rate in payment when other satellite hospitals are? Is that going to be part of the discussion?
Actually, I think that is the core of the discussion.
I was
That's
being
what-
nice.
And I think that's what this committee substitute does recognize, is, as the senator points out, is to level that playing field so that everybody has the same opportunity to get additional reimbursement in recognition of them serving a disproportionate number of Medicaid folks.
I knew, may I, Mr. Chair? I knew that was the direction that you're heading, but sometimes I'll ask questions because we have our constituents and the public who watch these, and we can sit here and, you know, having been in healthcare now for a lot longer than I care to share, we can have conversation and know exactly what we're talking about. But the vast majority of those who are watching even this discussion today do not understand the intricacies of the healthcare system, and I just wanted to make sure that it was put in terms that they would be able to follow. So thank you very much for that answer.
Any other questions or comments from the committee members? Again, this is a kind of unique situation. We want to try to pass this out so we continue to have these discussions, and we will revisit it again before the day is over. But we need to have this starting point. So that end, it is a little bit of leap of faith, but, you know, doesn't commit you your vote to anything other than this committee at this moment. So unless there are no further questions, comments, entertain a motion to approve.
Second.
Motion by Senator Nemes, second by Senator Douglas. Please call the roll.
Senator Rocky Adams. Senator Chambers Armstrong. Senator Berg. Senator Carroll. Senator Douglas.
Aye.
Senator Elkins.
Aye.
Senator Funky Fromeyer.
Explain my no vote.
Yes, please.
I continue to be very concerned with the direction of Kentucky and the fuzzy math. I look forward to better understanding. And I've got a pretty good brain for this, but I'm very, very concerned about this fuzzy math. Thank you.
Senator Nemes.
Aye.
Senator Tishner. Senator Wise.
Aye.
Chairman Meredith.
Aye. Motion carries. And thank you, gentlemen, for being here this morning. Committee members,
Thank you, Mr.
for,
Chairman.
Thank you.
excuse me, thank you, Senator Rocky Adams. Motion on title amendment, second. All in favor say aye.
Aye.
All right, thank you. This meeting is adjourned. Thank you.